Okay, let's get started as our participant numbers are climbing towards the 100. Hello, everybody. Thank you for joining us for this ACOSS UNSW Poverty and Inequality Partnership webinar on the challenges in providing equitable access to health in Australia. I'm Carla Trelaw, and I'm one of the partnership directors along with Cassandra Goldie at ACOSS. And I'm from the Social Policy Research Centre at UNSW. I'm going to hand over straight away to Uncle Alan Murray from the Metropolitan Local Aboriginal Land Council, who'll deliver the Welcome to Country. So over to you, Uncle Alan.
Good afternoon. My name is Alan Murray. I'm here to do the Welcome to Country. Under our traditions, we normally do a smoking ceremony and a dance and a song to welcome people, but here it's quite different because of COVID. I just want to acknowledge First Nations people who are part of this webinar. I also want to acknowledge other Australians who are part of the webinar as well. I'm here living in Marrickville on Gadigal land, and I've lived in Sydney all my life. My mum's from Walgett, and my dad's from Cumminggunja mission between Chugum and Shepparton. And my dad is a stolen generation, and I've lived in, I suppose, one of those things about parents, they get together and they have a child, and guess what? I was born here in Sydney, so on the land of the Gadigal. I want to acknowledge also all other Aboriginal clans of New South Wales. I want to acknowledge your elders, past, present and future, and also emerging. I want to give a shout out to the communities of Wilcannia, Burke, Ingonia, Bidurga, Walgett. I know you're doing it tough. Stay safe. Listen to the advice of health authorities. Listen to your AMS officials, and just make sure we are taking the jabs, because I've taken my first and second. So it's pretty important to make sure you go through the steps. With that, welcome to this webinar. Also, welcome to Gadigal. And also I want to acknowledge all the other Aboriginal lands where we've been part of this legacy. We've been here for 40,000 years, 60,000 years, 120,000 years. So I suppose under COVID, we want to last and prosper, and we want to be making sure that we can move on. All the best, stay safe. These lovely people are going to talk to you. Make sure you listen to them. They're going to provide the leadership, commitment, and also the advice to make sure we can get out of COVID. Thank you very much.
Thank you very much, Uncle Alan, and for the reminder about the communities across New South Wales really struggling or really affected by COVID at this time. In terms of this webinar, a bit of housekeeping to add. If you're having technical difficulties, please use the chat function to be in touch and seek help. And if you'd like to ask a question or pose an issue to any of our speakers today, please use the Q&A function, and the questions will be answered after the panel discussion. The webinar is being recorded, and we'll put this online within the next few days and disseminate and distribute that link. To take us forward, I'd like to introduce our host for this event, Dr. Norman Swan, who's the host of the ABC Radio National's Health Report, co-host of CoronaCast, and commentator on ABC TV 7:30. Over to you, Norman.
Thanks, Carla. And I too would like to acknowledge country. And one thing I want to say in acknowledging country is that, and I'm speaking from Gadigal land, part of the Eora Nation, is that the control of COVID in Aboriginal communities has been a huge success overall, and particularly last year. And one of the good things that the federal government did was actually to get out of the way of Aboriginal communities and allow community-controlled health organisations to really take charge with communities and control communities as a whole. Sadly, as Alan said, in Rurality country, there is a lot of pain at the moment, because once you break that community bond in terms of this virus, it's very hard. And any pandemic highlights the fractures in communities and finds all our vulnerabilities. And that's the core of this report, is that it may be about health, but what sits behind health, well-being, perceptions of health and well-being, how we feel, how long we live, what we die of, whether we're susceptible to COVID, all those things are determined by lots of things other than just metabolism or indeed access to health services. And so we have this broad view, which I'm sure everybody who has come into this webinar shares, but it's time for action and to capitalize on the mood of the moment to actually move forward rather than stand still. To talk about this report, to give you a sense of what's in it, is Evelyn DeLue, who is Director of the Centre for Health Equity Training, Research and Evaluation, University of New South Wales. This is a partnership between ACOSS and the University of New South Wales. And then we have an excellent panel for you. And I encourage you from this moment on to put in questions, comments in the Q&A box. Don't wait until the last minute so that we can integrate them into the conversation. Evelyn, over to you. Mute.
Unmute. Yep, here we go. I speak from lockdown on Gadigal land, and I acknowledge that this is unceded land, has been, will be forever. But my office, Chetra, is on Tharawal land in southwestern Sydney, and that is where inequities are rife. And that is why I'm so interested, fascinated with work around work income and health inequity. And I will share my screen. I only have 10 minutes to talk about this is not going well. To talk about complex matters. Here we are. So I'm only giving you a snapshot, and the ambition of our report really was to map across Australia inequities in health. And we know anecdotally that there are vast inequities. A man in the local government area of East Arnhem in the top end can expect to live on average no more than 44 years, whereas a woman on the northern beaches of Sydney can expect to live on average 86 years. Now that is a vast difference. And we see not similar, but equally impressive differences and unacceptable differences in our working area. So the ambition that we had in doing this report was to provide a map of the differences in health and how they relate to differences in income, socioeconomic status, access to services, etc. That is not very spectacular or novel or anything. That is in fact something that has been done by Michael Marmot in Marmot reviews around the world, and many national health authorities around the world actually do that. If you look at equity in health in the Nordic countries, they have fantastic publicly accessible maps about equity in health and the causes of equities and inequities. So our ambition was clear. We wanted to map hotspots of disadvantage. What we quickly found was that for Australia, such mapping is not easily done. So we got the project funded by the partnership as one in a series of ideas and analyses around inequity. And we studied what data is available and how accessible that is. And we found a troubled reality that it is not easy to find good data on the distribution of health and its relation to socioeconomic difference. So we workshopped with a number of partners, including CoHealth, the Centre for Primary Healthcare and Equity, FIDO, which is the national mapping agency that makes social atlases for health. They're based in South Australia. With the Australian Bureau for Statistics, the Centre for Research Excellence in Health Equity. We workshopped the opportunities and the challenges and how you actually, as Norman suggested, find solutions rather than identifying more problems. So this is a first step in a larger, longer term project where we actually want to generate those solutions. So we start off with health indicators interlaced with various socioeconomic indicators, mostly financial or finance related, like employment status and CIFA status. And CIFA is a compound index of disadvantage around Australia. First, why are some people healthy and others not? This has been a question that's been asked for decades now. This is the book that explains it, but doesn't really tell you how things are going so wrong. It tells the story of how we have evolved our thinking around health and health inequity and what causes it. So, you know, traditionally doctors think about disease and healthcare and its interaction. And then if there's mysteries, there's some other factors there. And we need to study this. There is an industry that studies this, clinical epidemiology, health services research. But most of that industry doesn't really look at the factors that drive these differences: social environment, physical environment, and our genetics, and the relations between all of those different things. And one of the things is our individual response. Rich smokers, for instance, mysteriously develop less lung cancer than poor smokers under exactly the same circumstances. So what is going on there? And that has to do with the whole complex context of equity in society and the Gini index, for instance, how fair we are as a society. And we may think that we're fair in Australia, but the evidence in our report shows that we're not that fair. So the key findings in Australia are that there are clear inequities, as I just suggested, and they're linked to our socioeconomic status. And what we know is that people reliant on welfare and government income support do report mental issues, psychological distress, but also more chronic disease. If you're lower on the income ranking, you report much more chronic disease, but also other diseases, including infectious diseases like COVID. If you're unemployed, you're even worse off. If you're in paid work, and even paid work at a similar income as one if you would be on welfare, you are healthier. Poor working people are healthier than poor unemployed people. So there is a social context to all of this, and that is not an easy context. Work is in itself a complex endeavor. So chronic conditions are the greatest burden of our disease in our society. And what we need to do is to figure out a better framework and better data to measure health equity more effectively. We need to have transparent, publicly accessible, policy-ready data about differences in health in order to take action. And overall, and I will quickly go through a number of graphs that we did, people with lower socioeconomic status generally have worse health than those with higher socioeconomic status. How do you make policy for that? Well, that is, the policy shouldn't be sectoral. It shouldn't be building more hospitals or providing more drugs or promising more vaccines and then not deliver. This is a complex problem and we need to have complex solutions. Fortunately, we can advocate very well for those complex solutions because the people on this panel today represent agents in that complex environment. So how do we address that complexity? And especially through ACOSS, we have experience across all of the determinants of health. Conflict, inclusion and exclusion, early childhood development, housing, food security, working and life conditions, they all and others are impacting on this. And in fact, what we know, and we haven't been able to actually map that across Australia, but the earlier you start working with children, educating children, the first 100 days, the first 200 days, the first 2,000 days are critical for the health of populations and the equity of health among populations. On socioeconomic indicators, we looked at 4 of those: household income, labor force status, employment, non-employment, welfare recipient or not, main source of weekly income. Some of the graphs that I will show you are a bit complex, because you see that people on the lower rungs of income actually are not as bad as you would expect. And that is a statistical artifact. And I hope we don't have to discuss that. We're not among statisticians, but it is an interesting finding. And CIFA, as I said, a compound index of disadvantage in Australia. So overall health status, how people rate their own health. And you will see here that in deciles, so 10% roughly across populations, people who are richest feel healthiest. And in the second decile, so not the absolute poorest, but in the second decile, people feel not very healthy. And the same thing is related here along CIFA group, so the compound index, which also has to do with your social status, educational state, etc., etc. So you see here how people derive their income from being employed or being on a pension already, or actually not being in the labor force anymore in other ways. And I want to stop really with talking about mental health conditions, because you see here that more mental health conditions exist the more financially strained or the more income deprived you are. And this, in fact, is not just a finding that we find across Australia or at the local level. We just completed a project with our Canadian colleagues in the University of Alberta in Edmonton. And we find that financial strain, so not poverty in itself, but financial strain, the sense that you're poor, creates so much stress for people that health does become an issue. Mental health becomes an issue, and people are struggling with identifying a way out for their future. So mental health really is a challenge, and we are in the process of developing a guidebook for how to deal with this. And it's not just structural intervention, it's also showing that you care amongst each other. I'm stopping there because my 10 minutes are far over. Do download the report, and you can actually appraise all of these interesting graphs and figure out how we need to move ahead from this. Thank you.
Thanks very much, Evelyn. Remember to keep your questions coming in, and we will get them through to the panel. Don't wait until they're actually a question for you, Evelyn. Just so let me introduce the panel to you. Let me get distracted here. Nicole Bartholomeus, hi Nicole, is Chief Executive of CoHealth. That's a network of community health centres in the Northwest Corridor of Melbourne, looking after about 150 different cultural groups in Northwest Melbourne, with a very comprehensive health service where general practice is just part of it. Nicole Kilby, who is a policy officer with the National Association of Aboriginal and Torres Strait Islander Health Workers and Practitioners. Welcome, Nicole. And Erin Miller, who is Manager of Priority Populations and Places with Sydney Local Health District. Hi, Erin. Evelyn, just a question here from Andrew Giles is, what do you think of quality of life measures as a way of comparing cohorts?
There's a simple and a complex answer to this. Of course, they would work, but there's an entire global network of quality of life researchers that have codified how you do that. Ultimately, asking people themselves how they rate their quality of life is a most important index for that. Sometimes you get distortions there. Quality of life is not the same as health, and people in terminal health can still have, amazingly, or feel that they have a great quality of life. So you're measuring slightly different things, but they are, as a proxy, very good measures.
Nicole Kilby, in a sense, with good granularity, the report describes some of what we know with a little bit more detail. But as an Aboriginal woman and member of Rurality group, Rurality people who are just going through a very difficult time at the moment, I mean, this is front and center. And we talk about income, we talk about education, we talk about various things. Do you think you can dissect inequality down to those elements, or is it something bigger than that?
Yeah, so thank you. That's a good question. I think for Aboriginal and Torres Strait Islander people, we view health in the holistic context. So I guess that's probably where, how I would answer that. So that includes the mental, physical, cultural and spiritual elements of health. And so, to address these issues, we need to require the focus on social and cultural determinants of health. And that includes a collaborative intersectoral solutions need to be put forward in that context.
I mean, it's easy to assume that the solutions here are health solutions for health inequalities. Do you believe they are health solutions? I mean, I'm doing you out of a job here potentially.
I think that's probably no. It's definitely while it is like health should be involved, I think it's for all sectors. All sectors need to be involved in the responses, and we need that cross collaboration and that interconnectedness because the issues are so complex. And so, we can't expect for Aboriginal and Torres Strait Islander people to focus on their health or worry about their health, which we already know is behind other non-Indigenous Australians if they don't even have adequate housing to support them, in the first instance, or employment. Sorry.
No, it's fine. Nicole Bartholomeus, it's easy to jump to the conclusion that the biggest structural problem is money and income. And in a sense, Evelyn has illustrated some of the paradoxes there. What's your take on that?
Look, I agree. There is it is easy to focus on the money, but it's clear from the report that ACOSS and the University of New South Wales produced that income status, your employment status, your level of education is absolutely a determinant for your health outcomes. And so, as a healthcare organisation in Victoria, providing a whole range of health and wellbeing services to vulnerable people, vulnerable communities, we know that the care that we're delivering is essentially a band-aid. We need to be addressing and influencing policy so that we can deliver better outcomes for people. If people have access to a decent income, secure, stable housing, we know that their health outcomes are going to be much better. They're going to be able to access care, they're going to be able to be connected to that care and achieve better health outcomes.
I'm thinking of I'm contradicting my own question here, but there was an interesting study of income in a Native American community. I think it was in North Carolina, and they were able to track an intervention in that community which raised income. So they had a before the intervention, which raised income, average income levels in a poor community. They studied during income supplementation, and then that intervention went away and they lost income. And in a sense, we've gone through exactly that experiment in the last year in Australia, where we've had the first wave of COVID-19. We've had income support for low-income people. That was removed. We're now back into outbreak and lockdown, but it hasn't been added back. It has for some people in terms of employment. What have you observed in your communities in the Northwest Corridor of Melbourne with that experiment and the difference that income support actually made, having led you down the track saying, well, this is all about other stuff rather than income?
People in the northwest of Melbourne, as are other communities across Australia, are really doing it tough. We're seeing people who were able to work in casual part-time jobs, able to sustain themselves, coming back to community health, needing a whole range of supports. You know, I've seen story after story of people saying that whilst they had the boost to the, or the supplement to the income, they were able to buy food and medication. They didn't need to make that choice. You know, I was able to buy a pair of shoes. I was able to buy some warm clothes. It's now, the supplement's now gone, and we're seeing people returning to having to make those really hard choices. Do I buy the medication I need to control my chronic disease, or am I buying food for my family? People are really doing it tough.
And are they coming forward with ill health as a result, either psychological or physical?
Absolutely. The increase in people's anxiety, depression, the increase in unmanaged chronic disease, it's absolutely having a toll. Plus, we're also talking about a vulnerable community that is more vulnerable to COVID. So they are more exposed, they are more susceptible. And I'm really interested to know and understand that for these communities, if they have COVID, how well do they recover? How well are they able to interact with the healthcare system, and how well do they recover from COVID, which I think is, you know, another area for us to explore.
An important part, Erin Miller, of this story is community. And Sydney Local Health District takes in some of the southwest corridor of Sydney, just a little bit. It's other local health districts that do it. But it seems to me that we've made, the New South Wales Health made exactly the same mistakes that they made in the northwest corridor of Sydney. They do not appear to have gone in with community development. They were late to endorse community leadership. You've had the health minister standing there blaming people and saying those people over there from different backgrounds. You've got different rules for the southwest corridor from the eastern suburbs. People look at the Bondi Beach and say, why should I do it when it's not equal? Why don't we learn?
I think from a local health district's perspective, I think, and you know, staff on the ground implementing this work, our population health team, our diversity hub, they've definitely heard those messages through the media and are working incredibly long hours over the weekends, just getting those messages that come from the Commonwealth and from the state, and translating them and thinking of really creative ways to get those messages that have been endorsed and approved and are trusted out to our communities in a way that's accessible to them. We've also, I mean, we can talk about it in a bit, but we've been doing some pop-up vaccination work in our southwestern corridor, taking vaccinations out to local facilities that people are comfortable with, working in close partnership with agencies like the local mosque in Lakemba and other agencies who, you know, we're coming out as health and we're delivering a message, but if we give that message to a partner agency who the community trust, it's so much more powerful. And we're seeing that knock-on effect. More people are attending vaccinations when the messaging comes from our partners and when we work in partnership. Sorry, I saw Evelyn's hand up as well. Did you want to add something?
I certainly want to add something, because as I said, we are part of Southwest Sydney Local Health District. And some of the observations about the people who don't comply with the rules just are an illustration of an amazing and I suspect even malevolent ignorance, because there's very little awareness of how people struggle at the coalface. That the housing situation of people in Southwest Sydney, if you're in an apartment block in a 4-story walk-up with a large family and you don't have green space, you can't let your children run in the garden still in lockdown, and you are with very large families interconnected across different apartments in the same block, and you say, no, stick to the rules. It is ignorant. And some people attribute it to culture. You know, there's a cultural difference between home and house. So if you say stay at home, that doesn't mean that you stay in your apartment in some cultures. And at the same time, home and house your environment are health-making things. In Indigenous health, for instance, we know that caring for country, being on country, being with country, is a health-making capacity. And to formulate messages through partners outside the healthcare delivery system, but in social services, but also through community leadership, that they reinforce those health-making capacities actually is part of the solution.
There's a question here from Penelope McMillan. How much do we know about cause and effect rather than just correlation? Does poor health lead to low income or vice versa?
Yeah, that is a very good question. And there is a correlation, but there's also a direct relation. We see that, for instance, in childcare, that low income forces people to sacrifice good childcare for their children. So in the long run, that has a very clear health effect. That low income doesn't allow you to provide all the care for your kids that rich people would be able to allow. On the other hand, there is this complex that I illustrated that has more fuzzy effects on health, and the other way around. Poor people tend to be unhealthy, and unhealthy people tend to be poor. And you have to lift people out of that, and a guaranteed basic income would be an absolute first step to just getting out of there.
I want to ask about the early years and those first 2,000 days, Nicole Kilby, and just getting that right start and those services organized, and what policy interventions need to occur, at least in Aboriginal and Torres Strait Islander communities, for those first 2,000 days to be properly addressed, given that that's the start of the process that can either lead to advantage or disadvantage?
I think there's quite a few things that need to happen to start with. So as I already mentioned, we view it in that holistic context. So to ensure that the health system and other systems are meeting the needs of Aboriginal and Torres Strait Islander people and communities, there's a number of changes that need to happen for equitable access. So, for example, one of those is to address the underrepresentation of Aboriginal and Torres Strait Islander people who are working within the healthcare system. There's a need to grow and strengthen the Aboriginal and Torres Strait Islander professional workforce and the workforce overall. And to do that, we need committed investment and support from government and mainstream services to do that, with a dedicated focus on jobs and training. And I think another important aspect is that racism and discrimination also need to be addressed and eliminated. Because the first thing is that Aboriginal and Torres Strait Islander people need is access to culturally safe care, especially during times of crisis, as we're seeing at the moment.
Thanks, Nicole. Nicole Bartholomeus, the question here from Jonathan Harms, which is, to come to the bottom line of his question, is poor mental health is something that can undermine every other domain. And what are you seeing in your own experience there?
Yeah, absolutely. I couldn't agree more with that. And, the work that we do with people who experience homelessness, and actually understanding, the impact of homelessness on someone's mental health, but also does the mental health actually cause homelessness? So it's an interesting and really complex piece to work with, but really seeing across the North and West, as many other communities are, the increasing prevalence of poor mental health, and the absolute demand on structures and systems and the workforce to actually support people and care for people with poor mental health has been a huge challenge. And I kind of think about the people's health and well-being, or the well-being of people's mental health as almost being, the third wave of the pandemic. We'll get through this pandemic, we'll we will eventually roll out the vaccines and people will be vaccinated. But, you know, the tsunami that's going to follow with poor mental health and needing to respond to that, and also all of the other unmet health needs that have been delayed or deferred because we're responding to a pandemic. So I think there's a huge challenge for us there beyond COVID in responding to that next tsunami of healthcare need.
Now, if you were to talk to the federal government, they say we're spending billions and we've increased the spending on mental health care by billions. Are you seeing the effects of that?
We're not directly seeing the effects of that. We have recently had a royal commission into Victoria's mental health system in Victoria, and there's a substantial investment by state government to actually fix the mental health system in Victoria. I'm confident that as that program of work rolls out, we will see significant investment in Victoria. The challenge is the workforce. As Nicole mentioned, it is, the challenge in actually having a workforce that is able to deliver the services required, a skilled and trained, experienced workforce to do that, but also a workforce that can deliver care in a culturally safe way, practices in a culturally safe way, and reflects the communities that we're working with. So at CoHealth, we're really committed to actually ensuring that our workforce reflects the communities that we work with, and understanding that you get better engagement and better health outcomes when the workforce reflects the community that workforce is working with.
Erin, a question here from Francine Crimmins, which is how important is health literacy in all of this, and the ability and empowerment for individuals to be able to navigate the health system? So it's not just health literacy, it's health system literacy. And you're dealing with communities where English is not the first language, multi-generational households, and people who come from political environments where they don't necessarily trust authority.
Yeah, I mean, I think they're three separate issues. There's literacy and there's ability to navigate systems. There's your skills in English, and also that pressure from or misinformation, I guess, from other sources. But I mean, with what we've been trying to do with vaccination clinics, in particular in this pandemic, and trying to enhance that access to clinics, the skills people have in terms of technology, the skills they have navigating an app on their phone to be able to make an appointment can create so much stress in an already stressful environment. So, people they're needing to get a vaccine to work. They're needing to get a vaccine to earn money for their family. So when they can't use the online booking system, their problem-solving skills just wither away. Their stress levels just escalate. So having clinics on site in communities where we can just book people in straight away, support people through that, has
how do you apply that? So how are you going to apply that next year when everybody's vaccinated? How do you stop it going back to where you were? What do you build in structurally to a health district that teaches you that there's stuff you've learned that you could build upon? I mean, this is stuff that Aboriginal communities have known for a long, long time. The control and community control is the core of is where you start. But it strikes me that that's not been learned in communities where English is not the first language and come from different cultures and different countries.
I mean, I think keeping our community partners on board throughout this journey, reflecting with our community partners throughout the journey as well, are going to present heaps of learnings for us. So, I mean, at the moment, we're working 7 days a week. Once we can get to a point where we can stop and say, okay, how could we have made that better? How are we going to communicate if we need second vaccines or booster vaccines in the future? How will we make that system better and more accessible? And how can we better work in partnership to make that happen? We're learning lessons every day at the moment, and it's incredibly powerful. So I think we just need to continue building on those relationships that we're forming and strengthening through our day-to-day work to have a plan to future-proof, I guess, the plan with these communities.
Evelyn, do you think you've got the data to ascribe the relative importance of different factors? And I'm thinking here of a question, Aaron Deneen's asked a question about SES as a system, income, status, discrimination, and so on, and whether adequate income is a pillar or a first step in a process when you move to intersectoral issues. Do we know what the best buys are? If you actually zeroed in, if you've got $1 million, where's the $1 million best spent? And the relative importance of the factors that you've just exposed in this report.
Yeah, we have some indicators for what best buys are, and if you like, I can quickly whip them up from the WHO website on chronic diseases. And that is active transport, for instance, is a fantastic best buy. Accessible food systems, health literacy. But they tend to be more proximal, focusing on behavior change rather than systems change. What does a system need to look like to enable those best buys? Because that is political choice. We need to make political choice. I have an example. Before I came to Australia 16 years ago, I was active in the Nordic countries in Europe, and WHO there wanted to know what is the best investment to reduce the burden of chronic disease. And we commissioned really big study, and Edward Melwish from Oxford found that reading to your baby is the best investment in life and in the reduction of chronic health conditions. So WHO then had to formulate that into a best buy. And reading is not an option for everybody. Simply because you don't have money to buy books, or you don't have time to actually take your child on your lap, or you think, what is reading? So storytelling was the thing, and care for your child, and invest in parental leave systems. So it is trying to figure out as a best buy that system around one of those good solutions that makes things work and acknowledge the politics.
Another question comes from Elise Fixon. Nicole, let's come to you on this. And it's about digital health literacy and the digital divide, and how much that is contributing to health inequities and the health gap.
Yeah, thanks, Norman. So it's interesting when we think about COVID-19 and the impacts on vulnerable communities and the health inequity it's shown. I always take a step back and say, actually, those inequities existed before COVID, and COVID has shone a light on where they exist. We now have an incredible level of awareness of these cracks that have been there for a very, very long time, of a number of communities that just have not had access to the services that they need. The digital divide is an interesting one. We have supported thousands of people across the north and west of Melbourne who are or have been recovering from COVID. We've put a program in place which provides medical triage and medical care, but also social support so that they can quarantine safely. And it really highlighted to us that people don't have a device or access to the internet or even a credit card to be able to order groceries online, just to be able to get the basics. To support our homeless community in the Melbourne CBD, we handed out mobile phones and iPads so that they could remain connected to the world. They had a connection to us. They could see the news. They could hear what was happening. There is a massive digital divide, and I guess the socioeconomic status of people really highlights that digital divide. Again, it's the people from vulnerable communities, from lower socioeconomic cohorts that do not have the means and the access to digital technology.
I'd like to, Therese Watson asks, she comes from Southeast Victoria, large asylum seeker population, and she asks about the role of trauma, and of course the community that's most traumatized right now is the Afghani community amongst these, in that corridor. And what role does trauma play? And I might just apply that, start with Aboriginal communities, which have had more than their fair share of trauma, and where trauma fits into this, and dealing with trauma either directly or directly, because sometimes you can make trauma worse by dealing with it directly. What's the nuanced or approach you think, Nicole Kilby, to trauma as part of this story of inequality?
Yeah, I guess it comes back to dealing with trauma, obviously, is a very big, complex issue. And that's again where we need that workforce and we need that support to be able to have culturally safe Aboriginal counsellors and, workers who can provide that support for Aboriginal and Torres Strait Islander communities. Obviously, they know the issues that are affecting their communities, and so they're best placed to be able to provide that support and help with those issues of trauma. But that's again where we're lacking in workforce numbers and support from government and commitment to build that up.
Erin, you must be seeing the side effects of the complications of trauma, not just trauma with COVID, but you're dealing with communities who've arrived in Australia already traumatized, sometimes with unspeakable experiences.
Yeah, and I mean, that's having trauma-informed clinicians, and I guess what's with our response, even with the testing clinics that we've done testing clinics in the past, pop-up testing clinics in areas of high density public housing, and even with the mobile vax clinics that we've been doing, having some of our most senior mental health clinicians, social workers, staff who are really well educated on trauma-informed care, coming along to those clinics, not to vaccinate, but to just talk to people in the queue, talk to people before they walk into the clinic and to book them in, and talk to people afterwards and reflect on what's just happened in the clinic and their experience has been really powerful. I think it just, I guess, helping people manage their behaviour when they're in a really, this is a scary time. Going and getting vaccination can be scary for some people. And if they've got that trauma background, they're going to respond a little bit differently. So we've really directed quite a bit of our workforce to more than just vaccinators, our trauma-informed workforce towards the vaccination and testing effort. And I think that needs to continue.
But Nicole, follow me, it's one thing to intervene, laudable though what Erin's just talking about is, which is that you've got an objective and insight, which is to help people through a very difficult time when they're going through lockdown and quite a degree of community prejudice. But there's also the healing of trauma as a way of reducing inequity. What's the infrastructure for healing trauma, or can we heal it?
Yeah, absolutely, we can. We've have lots of examples where we've worked with people, supported people to recover from trauma and be able to be, reconnected and engaged with their lives. And I was just going to add to Erin's comments around at CoHealth, we use a peer workforce. So we have a number of peer workers across a range of services or a range of disciplines who have lived experience, and a lived experience of trauma is very important and very powerful when you're working with, with people, with clients, with patients who have suffered significant trauma. Being able to connect with someone at CoHealth who has also had lived experience of trauma, build that trust, build that relationship, support them to engage in services, very important. And we're seeing that with our rolling out our vaccination program to homeless people. We actually have a number of peer workers who have experienced homelessness, and they're actually the ones that are out on the street, engaging people who experience homelessness, encouraging them, supporting them to come to our clinic to have the jab. So it's, I think peer workers really play a significant role.
Evelyn, you talked in your data about how if you put two smokers who are smoking 20 a day side by side, the person who's gone further in education will live longer. Michael Marmot's shown that if you put people side by side who've got the same education, but they come from different countries, Americans will always live shorter than, say, Europeans, British, or Australians. It just shows you the complexity here. And we don't fully understand the roots there. Part of it's about control and what have you, and income. But it's also, and social infrastructure. But it's also about, another one of those conundrums is rurality. And you talk about, you've used the data from John Glover, who's got quite granular data on inequality throughout Australia. And what he's shown is that rurality, if you put people side by side in what looks like the same circumstances, if one person comes from a rural area, they come off worse too. That's a factor for inequality too. And this I'm taking, and I'm picking up on a question here from Eileen Brownless, which is, how does this work incorporate the rural voice and circumstances? And do we know what they are?
Well, we know insufficiently what they are, and one of the challenges is that, and we addressed this earlier, this is not about healthcare delivery. It is not about access to services or how fast an ambulance can be at your doorstep if you live 200 kilometers out of the next facility and you have a cardiac arrest. It is about connectedness, one of the challenges in mapping these data is that health data are not collected at the same level as socioeconomic data. So we know exactly where people live, but we don't know what health conditions they have where they live, simply because those data are collected at other places, hospitals, or through more distal mechanisms. So we can't correlate all of this appropriately. What we do know is that people who live rurally and remotely are worse off than people on average in cities. But within cities, you have an incredible variety of inequities.
But we have data linkage now, don't we? I mean, New South Wales is particularly sophisticated. West Australia was the original state. It's fallen behind in this, but we have pretty sophisticated data linkage now where you can link data sets from justice, housing, through to health. I mean, it's inadequate, but it's there, isn't it?
Yeah, it's there, but it's inadequate, and it's not publicly accessible. You have to do a lot of procedural work, not just necessarily statistical work, but procedural work to make those data speak to you.
So we're running out of time at the moment, but so what are the data investments that need to occur? Because sunlight is one of the best cures, that if you actually shine light on this, you've seen this with the vaccination rollout, that Lieutenant General Froon has actually been better than the health department, much better than the health department, at showing transparency of data, because he knows that you can only achieve things if you've got data to compare it to. What are the investments in data that need to occur in order for sunlight to be shone on the health inequity issue?
Well, I can only speculate, but this is one of the things that we need to follow up on in a next stage, and the partnership. And I'm always tempted to hand over to Carla, who has some ideas about this, because our colleagues in her centers actually sit on top of many of those data.
Carla, do you want to pick up on that? You'll have to unmute.
I'm unmuted. I think that's a big topic for perhaps another day to unpack how we're going to do all that. But it is a massive problem that to be able to, as you said, Evelyn, make these data speak to us in a way that's useful.
Thanks, Carla. And just a really easy one to finish up with, and I'll get each of your comments, is which comes from Tony Wren. How do we help convince the Prime Minister and federal government to recognise that they need to increase base income support payments to help reduce psychological stress? Nicole? Much as you don't want to unmute, you'd better.
I was just wondering which Nicole you were throwing.
Oh, sorry, Nicole was on this. I apologise.
You might have to repeat the question again. What was the question? Sorry. No.
Well, it's the easy one of the best way of convincing the government that you actually do need to increase these support payments for low-income families which we're not doing at the moment?
Yeah, look, it's easy question, hard one to answer. We've been long advocating for an increase in the social payments for people who are unemployed, and clearly demonstrating the impact of those low payments and what that means for people's health outcomes, but also upstream the cost on the healthcare system more broadly. So if we're actually not investing in people's basic incomes and enabling people to have good health, to be able to self-manage, then we're placing additional burden on the healthcare system and all those costs upstream. So, I think we just have to keep raising the issue, keep highlighting and spotlighting what those issues are to influence policy.
With the data to support the story, as you just said.
Absolutely. And look, it's often what gets measured that matters. And so if we can spotlight the measures, if we can highlight those measures, get them out there in the public, collect the data to be able to report on those measures, then absolutely that'll have its moment in the sun.
Look, thank you all very much. It's been a fantastic discussion. Erin Miller, Nicole Kilby, Nicole Bartholomeus, and Evelyn, thank you all very much indeed. And I might hand over to Carla to close.
Yeah, thanks very much, everybody. And before I go into detail, I want to reiterate that COVID has shown these patterns of disadvantage and its associations with health in a very dramatic way, but we just can't sit back and observe this. We have to advocate for more nuanced and sophisticated action. And ACOSS and partners have produced an open letter calling for a variety of responses about specific vaccine targets for specific populations, transparency of data, the involvement of trusted community leaders, support to the social security systems and housing protections. So the link to that open letter has been posted in the chat if people want to go and collect it and review and see what work their groups or organisations might also be able to contribute to doing something that's urgently needed. So I will move to some thanks and closing, and firstly to Dr. Norman Swan as our host. Thank you so much for being a part of this and lending your voice to amplifying what we think is a really important and urgent issue to address. To our panelists, Professor Evelyn Deleu, Nicole Kilby, Nicole Bartholomew, and Erin Miller, for such a deep and enlightening panel discussion. Thanks to all of our attendees who asked questions and contributed. The Poverty and Inequality Partnership is supported by a range of people, and without them we couldn't do this work. So lots of thanks to UNSW Sydney, the Australian Red Cross, the Brotherhood of St. Lawrence, Good Shepherd Australia, New Zealand, the Salvation Army, Co-Health, thank you Nicole, Mission Australia, St Vincent de Paul Society, National Council, the Smith Family, Anglicare Australia, BB&A Miller Foundation, David Morowitz's Social Justice Fund, and the Australian Communities Foundation Impact Fund. Although that's a long list to go through, it's really important to show how important these issues of poverty and inequality are to such a broad section of agencies active in Australia. And thanks also to Penny and Danny working so wonderfully behind the scenes to make things go smoothly. Thanks everybody. There'll be more to come from our partnership. Please keep a lookout for it. And stay safe and stay warm if you're in Sydney.